crazy to compare. You can't find any reason anywhere. And if you're ever at your wit's end, we are here for you, our friend. Don't go crazy when the judges are clean and had a good day. When things look hazy, 'cause there's nothing left of 25 and don't get angry. Get mad today. I'm gonna help you through it all, 'cause you, my friends, are beautiful. We're gonna get you through it all the way.
Hello, everyone. This is Shannan. Hopefully you can all hear me. This is Shannan Mackey from the Law Office of Melissa Day, and I'm here today to give a presentation on the new medical treatment guidelines for occupational interstitial lung disease. Joining me today is Melissa Day, herself.
And I'd just like to brief shout out to Leah Zakari for our amazing theme song. I just get tickled pink every time I hear that song. It's so great. Thanks, Leah.
Great. So a couple things before we start this presentation. First of all, I'd like to apologize if I mispronounce anything. There are a lot of incredibly large words with many, many vowels in this presentation, so hopefully I do well. I keep mispronouncing alveoli to be much, or alveoli to be much closer to ravioli. So that's one. The other thing is, because interstitial lung disease is a very dry topic, and I don't just mean the cough, but we are doing a little prize setup with this. Interspersed throughout the presentation is titles relating to the actual topic at hand. In this slide with the title is a little thumbnail picture of the artists. There's 10 of them in total. Melissa thinks they're very esoteric and broad ranging, so she would be surprised if anyone is able to get all 10. But Melissa has graciously offered to up the ante for it and give a prize of two $25 Amazon gift cards to whoever, or to the two top people for this. The rules are, if you need to name all 10 artists, or the most, whoever gets the closest to all 10 artists, since apparently that's very hard. Any ties will be done based on who sent them in first, and all entries need to be in by 4 p.m. because I'm not going to be doing this all weekend.
But kudos to you for coming up with a contest. They're fun, but they can be challenging to create rules.
And in addition to that, if you have any questions on this topic that you'd like to ask me after the presentation, feel free to do that as well. So without further ado, I just had to,
Try advancing the slide and see if the song goes off.
There we go.
Okay.
Our presentation is Every Breath You Take.
Well, that one's not that hard.
The new medical treatment guidelines for occupational interstitial lung disease. So in case anyone didn't know, and this isn't a slide this isn't a thumbnail that has anything to do with any sort of artist. There are new guidelines that are effective 1/21/2021. The board has new MTGs for ankle and foot injuries. I think it's actually supposed to be 1/1/2021. Is that what you're going to say, Melissa?
No, I'm still hung up on the contest. So do they have to name both the artist and the album, or just the artist?
Just the artist.
Okay,
just the artist.
All right, just wanted to clarify that.
I don't know the albums.
Yeah.
The songs are in there, but I don't know the albums.
But they don't need the song, just the artist.
Just the artist, yes.
And yes, now that you mention it, it does look like there might be a typo in there.
Yes, that should be 1/1/2021. So they have new MTGs for ankle and foot injuries, which was the subject of the last presentation from Josh and Brian, if you haven't seen it. Elbow injuries, hip and groin injuries, and then today's topic, occupational interstitial lung disease.
And there are proposed guidelines too, I believe, for the hand maybe in the elbow or the wrist and the elbow, but they're still in the comment period, I believe. So those are not due to go into effect yet.
Okay. And these guidelines, Brian and Josh touched upon it in the last presentation, but there are some changes to Section A, the general guideline principles that apply. And so these changes that they specifically touched on the changes, and I will as well in the next slide, actually apply to the past MTGs as well. So if you look in that very introductory section on the left, it says the principles summarized in this section, and then at the bottom it goes, are applicable to all workers' compensation medical treatment guidelines. So the changes that they make in Section A do apply to the old non-acute pain guidelines, the back, the neck. Section A has essentially been revised by these new guidelines, and it's the same for all 4 of the new guidelines. And that revision does apply to the 2014 guidelines as well by that language. The changes, though, are just on acuity. A6 actually defines acuity, acute, subacute, and chronic, which are used throughout the guidelines, are actually given generally defined timeframes and disease stages. So acute is less than 1 month, subacute is 1 to 3 months, and chronic is greater than 3 months.
Wow.
So these now will apply to all of the guidelines according to Section A.
It's interesting that the board uses the term chronic because they go to such lengths in the non-acute pain medical treatment guidelines to emphasize the use of the word non-acute as opposed to chronic.
That is interesting. I didn't think about that. But so I guess the non-acute guidelines would apply to anyone who's had the injury more than 1 month at this point, just by it being less than more than acute. They also discuss the initial evaluation, which it refers only to the acute time frame following an injury, so the less than 1 month, and is not used to define when a physician first evaluates an injured worker in an office or clinical setting. So I thought that was an interesting change as well. This again is not actually part of the contest, but it's just a fun clip.
That's one of the best movies ever.
I do like it very much. Section B does explain what interstitial lung disease is, and it's actually the majority of this guideline is explaining what it is and how we determine what occupational is. Interstitial lung disease is one classification of an occupational lung disease. So there are a ton of other diseases that could be lung diseases that happen in an occupational setting. Interstitial lung disease is just one of them. Interstitial lung disease, however, is a group of more than 100 diseases that inflame or scar the lung parenchyma and affect the lung interstitium. Asthma is not an interstitial lung disease. It's also not a pleural disease. If anyone had any run-ins with 15.8, they know that there are some differences between pleural diseases and interstitial diseases and what's covered under 15.8. Pleural diseases are, for example, COPD, pleural effusion, and pleural mesothelioma. And I will discuss the difference between the pleural parts of the disease and what specifically is interstitial later. And also, these guidelines were made before COVID, or were written before COVID was something that was involved in us. COVID-19 can cause the same lung fibrosis due to the ARDS, but it is actually different than the fibrosis or they believe currently, because it changes all the time, that it's different than the fibrosis caused by interstitial lung disease. So it really wouldn't relate to COVID either.
What does ARDS stand for?
I don't remember.
Okay.
But I think reactive disease is the
airway reactive disease or something.
Yes, I think that's what those ones are.
And I've always heard it pronounced parenchyma. Have you not heard it that way?
I've never heard it pronounced.
Oh, okay. Well, from now on, I'm going to think of it as parenchyma then.
Okay. They do also note in these guidelines that asthma will be addressed in an upcoming guideline. However, it doesn't appear to be under any sort of period of explanation. So occupationally induced asthma will be something that's addressed later on.
Does this slide have an artist in it, or is that just?
This slide is not involved in the contest. It's just my favorite TV show, which is Doctor Who. The TARDIS is behind me. So, all right. So going back, and these slides will involve the contest. So how do I breathe? Just a brief description in case you didn't know how the lungs work. The lungs are like bellows. They don't actually have their own muscles. They expand to take in oxygen and contract to expel out carbon dioxide. Now, the outside layer of each lung has a sponge-like tissue called pleura. And this is where your pleural diseases happen, on that outside of layer of the lung. So mesothelioma and those types of things occur in that area. When that area expands, the oxygen travels down the windpipe or trachea and into the bronchial tubes. The bronchial tubes in that first circle are the larger blue sections. Each one of those little twigs that come off is the bronchioles. These are the areas where you will find the alveoli. The alveoli are the little air sacs on the bronchial tubes, or at the ends of the bronchial tubes, and each person has about 480 million of them. The interstitium, or where interstitial lung disease happens, on the wall of the alveoli. If you look at the last picture, it shows that yellow line. That is the wall. The oxygen actually travels out of the wall into the capillary or into the bloodstream, so it can be distributed through the body. The carbon dioxide travels in the reverse way from the bloodstream into the alveoli to be expelled out of the lungs. The wall is where the area we're talking about on each of those 480 million little alveoli. And again, another one. So if you do become breathless from the alveoli, it's because your alveoli wall is too thick. So in the first picture, we have a normal one, which is tiny, and then there's a thin tissue wall, and it becomes later damaged and thickened, which makes the oxygen and carbon dioxide slow to move through. For the acute injury stage, it's edema and inflammation. And when it turns into the chronic injury to the interstitium, you have fibrosis, which is the thickening and scarring of the connective tissue. Fibrosis in any really part of the body is the end stage of chronic inflammation. In this case, interstitial lung disease is also known as pulmonary fibrosis, or the fibrosis in the lungs is pulmonary fibrosis or interstitial fibrosis. Interstitial lung diseases are a group of chronic, generally irreversible conditions with vigorous immune and inflammatory responses and excessive collagen deposit. So part of the problems here is that your body actually creates an immune response to the things you are breathing in, which actually is your own body causing the damage itself by fighting what it's taken in at the alveoli level. And we'll talk about the specific interstitial diseases in a little bit. There's several types of interstitial lung diseases. There's exposure-related, autoimmune-related, and idiopathic. As I noted, there's over 100 of them. Not all of them are occupational or environmental. Interestingly, rheumatoid arthritis, lupus, scleroderma, Scourgeon syndrome, which is something we see all the time on medical records, can cause interstitial lung disease. Idiopathic is when the cause is unknown. There are typically findings you can see on the lung scan to differentiate these, which is part of what the guidelines go over. Exposure related is drug induced. There are 4 drugs that do cause this interstitial lung disease, which is why you need to get a very, very detailed medical history, as we'll go over. And finally, occupational environmental, which is inorganic or organic dust, gas and fumes, and radiation. And that's going to be the focus of the remainder of our presentation. So this, I think the picture is easy for this one, but the song might not be as easy. But you only need the artist. With interstitial lung disease, it's more than just having problems with breathing. You can also be responsible for a dry cough that interferes with sleep, where you could be responsible for sleep aids. There are various cancers that can be caused by interstitial lung disease. While I noted in the previous slide that autoimmune diseases can cause interstitial lung disease can also cause autoimmune diseases.
Wow.
So you might become responsible for rheumatoid arthritis, which we'll specifically talk about one of the types of interstitial lung diseases that basically causes rheumatoid arthritis. Restrictive diseases you'll be responsible to, which is just trouble fully expanding the lungs, which you kind of expect with a lung disease. Pulmonary hypertension, which is high blood pressure specifically in your lungs. The interstitial lung disease, because the oxygen is not going through and causes problems in your heart as well. The right ventricle can actually change in its function and structure once you develop interstitial lung disease, where it doesn't look the same or pump as efficiently, which also leads to congestive heart failure. And you also can be responsible for lung infections due to loss of host defense mechanisms. So if you have your pneumonias and other types of infections of the lungs, you really need to, you will be responsible for them, and you also need to get the treatment done very quickly. While not everyone has a lot of these cases that they might have seen in the past, any of these cases that I have been involved with or seen have always been intensely expensive. The last one I dealt with, it was an interesting one, because in addition to paying for all of these medications for the claimant, he was also trying to have us build him a new roof. Because he claimed that he would be able to fix his own roof on his house if it wasn't for his comp injury involving interstitial lung disease. So that was just an interesting one. We won. We didn't have to do a roof, but they can become enormously expensive claims, and oftentimes with the cancers and other issues like congestive heart failure, they do lead to death claims ultimately, where you're still responsible after on, or later on. So I think it's important to make sure we're diagnosing these and appropriately defending these from the onset.
This is a very broad identification of what I'd previously seen frequently as comorbidities in interstitial lung disease claims, but that didn't necessarily include the inclusion of all of these conditions or some of these conditions as part of under the auspices of the claim. And I would tend to think that based on identification of these additional conditions in the MTGs, that we may see the addition of these, what I would have considered as just sort of comorbidities, but actually appear to have a causal connection with the underlying lung disease. We may start to see more and more of these conditions actually identified and included specifically within a claim.
Yeah, that I've seen them kind of involved, but I also have only seen very, very few of them. So that could have also been a failure on the part of.
I've the identifying these conditions, which seem to frequently accompany people who have interstitial lung disease, as sequelae of the condition, as opposed to simply, there being a coincident finding, is something new for me.
Okay. Yeah. One of the things, the guidelines, and this is not related to the slide at all, I just didn't know where to put it in, and it's really important for all of our new slides. But latency is a super important definition with these interstitial lung diseases. And B3A defines it as the interval between initial exposure and the onset of symptoms/diagnosis. We'll talk specifically about it, but latency is the reason why you might have these claims appearing from someone who hasn't worked since 1992. So that's an important note. So the board specifically outlines in depth 4 broad categories of interstitial lung disease. And the first type they go over is the pneumoconiosis diseases. And they specifically give sections for the 3 most common of these: silicosis, asbestosis, and coal workers. As you'll see, for all of these diseases, your latency can last into decades, but it can be years for the silicosis. Did you have something, Melissa?
Oh, no, I was trying to remember what the specific disease was for coal workers, and I see it there. It's anthracosis.
Yeah. So I'm going to start with silicosis. It's exposure to crystalline silica, and it's irreversible and very common. It's estimated that there's 1.7 million US workers who suffer from this disease. The guidelines give a list of industries it's common for: mining, oil and gas, construction, foundry, pottery, manufacturing, sandblasting, and tunnel diggers. And they also give a list of consequential conditions: chronic bronchitis, lung cancer, tuberculosis, autoimmune disease, renal disease, and lung cancer that are specific to the silicosis. And I also included this because it's not in the guidelines, which is a horrific oversight in my opinion. But the longest English language word in the dictionary is the word for silicosis, which is pneumono ultramicroscopic silicovolcanoconiosis.
Wow.
That's my 5th grade. I heard that one before because I learned that in the 5th grade. So I had to throw that in there. And I'm going to skip the middle one for a second because a lot of people, especially with that longest English word, do associate that with coal mining and as the coal miner's disease or black lung disease, even though it's the silicosis. And one of the reasons is with coal workers, it's very often with silicosis. You won't find exposure to coal mine dust and graphite without also seeing the crystalline silica, which the guidelines do specifically note. For the coal workers, it's exposure to coal mine dust and graphite, mining, power plants, metals, and storage facilities can cause these diseases. In early stages, as Melissa noted, it's anthracosis, and it's called black lung disease in your later stages. This one, for consequential, it's rheumatoid arthritis and sometimes other autoimmune diseases. It's actually so common that having coal mine dust leading to these autoimmune diseases is called Kaplan syndrome. It has its own name because of how common this consequential condition comes up. And asbestosis, which is really the only one I've ever dealt with before in my life in comp. And this one is latency of decades. It's exposure to asbestos. Well, typically asbestos isn't really used now. You still have the older latency cases, and it's a lot of times seen in removing or disturbing materials now. Textile, fireproofing, asbestosis cement, tiles. For this one, you may also be responsible for lung cancer, mesothelioma, laryngeal, and ovarian cancers, in addition to the asbestosis, because they are known sequelae.
I've also seen colon cancer get established as consequential, bladder cancer, although the science behind those may have been a little suspect.
Asbestosis is weird with smoking. I don't know if anyone's ever experienced any smoking asbestosis/smoking litigation. You can be exposed to asbestosis and not get any conditions. But if you smoke, it's almost guaranteed that you will get it. And the IMEs create this kind of gray area then where they relate it to the smoking versus the asbestosis. That's an interesting thing to go in on, but it's really it exacerbates it. It's not really a mitigating factor where you can say it was the smoking that did it, although some of the IMEs do lead to that happening. and the guidelines specifically point this out. I think because at least I know I have used it in the past to defend a file on asbestosis and cause of death, that it was more related to the smoking than the asbestosis. So the guidelines, I think, kind of say you can't do that to some extent. The board is clear that this is not all-inclusive, but they do go through the other three common types. Hypersensitivity pneumonitis they give examples of bird fancier lungs, farmer's lung. Bird fancier lung is when people used to take care of pigeons on roofs, which I'm sure people still do, but that would be something that was common. It's exposure to animal protein, plant protein, bacteria, fungi, but it's also exposure to paints, foam, PVC pipes, and epoxy, which I didn't realize until I went through this part of the guidelines. I thought all of these hypersensitivity diseases had to do with more organic matters. The latency for this actually varies between acute, subacute, and chronic. It can be, you can have symptoms of this in a matter of hours. It often depends on the type of exposure that you had. This is interesting on this with latency because essentially it creates a sensitivity to the
Uh-oh. Shannon, can you hear me?
Yes.
Okay, you just cut out for a second, so we didn't hear your description about the sensitivity to the material.
Okay. So with the sensitivity, so latency can be hours, and this is important when we go down for the sensitivity because depending on the material, remember we said there's an autoimmune response earlier on that causes a lot of this inflammation. If you can catch it very early with these types of ones, you can actually give initial treatment before the sensitization becomes dramatic, where you can stop it in its track and it won't be that type of dramatic disease. They just need to avoid it. So these ones, it's not really something where if you do have this, I would probably say if this is what's there, try to get it treated, because you could end up, even if it ends up not being related, you could end up, saving a lot of problems later on.
Shannon, I don't want to steal your thunder if you're going to discuss this later on, but is there a discussion about accidental exposure in the guidelines as opposed to occupational diseases?
Is there? I didn't think there really was a discussion of that. There is a discussion later on in terms of, this is just the discussion of types. There is a discussion later on in how to diagnose it being related to occupational versus other, and by history mostly. But the guidelines, other than telling you the different types, don't really get much into the other stuff.
I'm just curious because if there is, I guess you can make an argument that the exposure to the material that causes the hypersensitivity, if you can argue that it occurs over a reasonably definite period of time, such that it should be characterized as an accidental injury as opposed to an occupational disease, and you are relying on a notice defense, then one of the things that you could point to as being potentially prejudicial to the employer or the carrier is the failure to provide timely notice prevents the employer from being able to provide prompt medical treatment, which leads to additional sensitivity to the material, which then leads to greater disability and possibly need for treatment.
I think that's actually a great defense to use. I know I had a case I was handling just of counsel. It was just a one-off appearance, but the person continued to expose themselves to fungi that they knew existed in terms of their employment. And if they had stopped, if they hadn't kept doing what they were doing, which was not necessarily for the benefit of the employer, and I won't get into the whole thing because it was a complicated case, but if he had just told them and stopped, it wouldn't have had the same level of disability moving on. And I think
Interesting.
I think that is actually an excellent defense to use where you can
Characterize it as an
yeah.
accident as opposed to an occupational disease.
Yes. They also want you to really watch out for differential diagnoses because these hypersensitive pneumonitis can relate to a lot of the idiopathic ones as well. And there is some discussion of that in the diagnosis section. For these ones, it's wood and food products can cause it, farming and painting, chemical manufacturing, and it's typically from cleaning items. If you do any water sprays, so anyone who does any like power washing on a regular basis or sand can cause it, and shedding from animals and renovations, which was the case I was just talking about. It was a renovation case. That wasn't the claimant's job. It had to do with renovations at the place he was given to live. So I think, but for these ones, the guidelines, and then if you do look into it, you can, this is not one of the ones that's irreversible at first. You can kind of stop this one from progressing if you do treat it quickly. The second one is really your metal diseases. It's exposure to hard metals. Years to decades is the latency period, and this is all in B4E. You'll see this with people who do work on nuclear projects, aircrafts and aircraft manufacturing, tool manufacturing, and electronics, any activities such as machining, grinding, smelting, metal products, and manufacturing. Berylliosis has one of the most severe consequential conditions that I think you can have. It's essentially your entire body systematically and slowly shuts down overall. So you basically have consequential entire body if that's what you get. And you have to be careful with these because beryllium disease is very similar, for example, to sarcoidosis, which is an idiopathic form of interstitial lung disease. And they're very hard to differentiate. So there can be a lot of confusion between these ones and the idiopathic diseases. So you have to be.
Oh, you froze again, Shannon. The wonders of wireless internet. Stand by, folks. Yes, Shannon is coming to us from the Jamestown, Mayville area. Not that the internet isn't great down there, but it's probably not as strong of a signal as it is up here in Amherst. Okay, so if everybody could just hold tight with us for a second and be patient. I will see if I can have Shannon email me the presentation and I can have her join by phone. So please stand by, talk amongst yourselves. There's a fairly lively chat going on right now about different types of dust diseases on the chat section. So I'd ask everybody to turn into that. And we'll be right back.
Oh no, it's me being subversive. Hello. I'm a monster. I woke Tyler up to say hello. He's so sleepy. Oh, Shannon's back.
Yeah, hi, sorry everyone. Let me just share my screen again. Close that, share screen. All right. So can everyone hear, or can you hear me, Melissa? Am I back?
I can hear you, Shannon.
Can you see my screen?
Give me 2 seconds here. I just am trying to start my video again. I can see your screen. I do not see you, but that's okay because I can hear you.
Okay, I don't think I started my video. Right. So I just finished with that one. Toxic inhalation injury, and this is where I do have questions because this is why I thought it was very interesting when Melissa mentioned accident versus occupational disease. Toxic inhalation injury is not really, according to the guidelines, does not appear to be something that happens over a large period of time. The guidelines specifically note that it's generally acute and related to other accident or disaster. And this is a severe lung injury from breathing in fumes, specifically types of diffuse alveolar related to nitrogen oxide, such as ozone, phosgene, ionizing radiation, and nitrogen dioxide. This latency is a matter of hours. There is no option for years or decades. And the guidelines really seem to indicate, when this happens, something went boom, and now you have a disease. So they still put this, though, on the realm of occupational disease rather than acute.
I have seen actually an asbestos case established on more than one occasion as an accidental injury as opposed to an occupational disease. Not necessarily a dust disease, but a toxic inhalation type of injury.
Right. The guidelines, though, do put this toxic inhalation in the occupational realm in B4F. Oh.
And don't forget, there's a question there for the
Yes. This one's hard. Breathing in Fumes is a B-side of a very popular album, and the band I thought was very esoteric. I didn't actually know that's what they looked like. I thought it was I thought they looked much different.
Are you able to advance the slide?
No. I'm not. I'm working on that right now. Here we go. No. There we go. So this one, I'm only missing when I'm breathing. B5 of the guidelines is very lengthy, and it really discusses taking an incredibly detailed history of the disease. You need a history of the present illness, and the board's guidelines specifically give in this section what the treating doctor needs to have. He needs to have job duties, time at each job with decades into the past, exposure with at least qualitative description of intensity. The board's guidelines do say they would like a quantitative, but if you can't give quantitative, you need to give qualitative. So there needs to be a description at each job where there's exposure alleged that there was at least a lot of dust or something that gives the relevance there. You need the symptoms, when they began, any previous treatment, the obvious statement that the probability that the illness is.
Oh no. I personally find this portion of Shannon's presentation very interesting because I believe that the medical treatment guidelines have been most beneficial to us in the specificity that the board's been willing to lay out with respect to what's required in order, either in the process for requesting authorization for treatment or for requesting a variance, but also in being able to properly document the different conditions. So right here, I think that this slide that Shannon's presented is an area that's rife with possibility for us for challenging the opinions of physicians that somebody's condition is causally related. And again, I thank you for your patience. Please bear with us.
Hi, so I am calling in to finish this. Melissa, can you hear me? Oh no.
She's muted, but I can hear you.
Yes, I can hear you. Shannon.
Okay. So,
I'm just trying to get
okay,
to
good.
Oops.
And I don't know if is it frozen on that last screen. The only miss you when I'm breathing.
Can you see my screen? Oh, you can't see anything. Okay.
No.
Audience, I am on the slide that Shannon was on, I believe, when her last interruption happened, correct? Whoops.
Yes. So it should say past history is B5B.
Yes.
So there's a little bit of an overlap in history of the present illness and past history, but the guidelines, again, are very specific on prior pulmonary. All other systemic disease, and as we talked about earlier, because some diseases like any rheumatological diseases can cause interstitial lung diseases, you need to know that. They want all smoking history, a history of use of medications, vocational and recreational pursuits, imaging, surgery, and allergy history. And that is the, so we can go ahead and go on to the next slide, but the guidelines are very specific that this is the information that you need from the treating provider in order to make this diagnosis as causally related.
And again, as I pointed out before our most recent break, I think that this is an area that's rife with possibility for us with respect to the documentation that an attending physician has to show in order for there to be a valid opinion of causally related occupational disease.
Are we on the next slide?
Yes, I am.
All right. So the B5C actually discusses the physical examination. It gives vitals, and what you kind of would expect, and checking to see how they breathe. However, they also specifically describe a potential etiology review, and these are things that can demonstrate etiology or that the origins of the interstitial lung disease are not related to the occupational disease. Mucous membrane abnormalities, nasal polyps, swelling or discharge, clubbing. Clubbing is related to asbestosis, idiopathic pulmonary fibrosis, and some of your hypersensitivity interstitial lung diseases. You see, two of them would point to it being most likely occupational, but that middle one would say it wasn't. The anterior posterior diameter, so that's really just checking to see if someone's barrel chested. Scoliosis and kyphosis are all things that can show the time frame as well for when the disease kind of picked up, because if the barrel chestedness developed essentially as a consequence of the idiopath of the lung disease, you have an origin of when the symptoms truly started. You also need to review for for other diseases. You need to check the skin, dermatologically, abnormalities in the chest wall, adrenal glands, for neck masses, and fluid interface that could all demonstrate that these are other causes of the occupational lung diseases.
That's really interesting about the scoliosis and kyphosis. I had no idea that curvature of the spine might be related to determining the etiology of the condition.
Yes, it's really, if you want more information on it, look up more the barrel chested, because that really, and its relation to like emphysema and how the emphysema causes the change in the positioning of the spine and the chest. It's interesting.
Wow. Shall I advance?
Yes, please.
And we're on diagnostic tests.
So the diagnostic tests in B6 is not actually that long of a section. The guidelines specifically recommend that you do spirometry, oxygenation, which is just testing to see how well the oxygen is, chest radiographs, and this is very specific. You must have a specially qualified physician do this interpretation. So you should check to see if the request of the guidelines of who is doing it does match the person doing the interpretation here, because if it doesn't, I've seen some doctors who are just your general catch-all trying to diagnose these in terms of a comp claim. They cannot count. It has to be specific types of radiologists. And carbon monoxide diffusing capacity, which is really just breathing out and measuring how much carbon dioxide there is. The guidelines for diagnostic tests discuss static lung volume might be necessary based on spirometry, and the other tests here, sputum samples, CT scans, and a bronchoalveolar lavage, which is awful sounding, would depend on what the findings were on the other diagnostics.
Sounds like drinking bleach to me.
Yeah. An MRI should never be recommended. Invasive procedures are not really recommended, but they could be permitted if necessary. And a lung biopsy is only needed in very select patients, but it's generally not needed to make these diagnoses.
Really?
Yes.
Huh. Because it's on death claims, we always got lung tissue slides. I guess that's a different thing than a biopsy. So
yeah, well, it might. It seems to be that the guidelines are really recommending it for people that are still alive, but it could definitely would still apply for it. But the diagnostic test would obviously be different if somebody had already passed.
Right. Shall I advance?
Yes, please.
And we're on.
And this brings us, yes, treatment. Just breathe. This is the smallest section of the medical treatment guidelines for interstitial lung disease. The B7 is not very detailed. It basically tells you should avoid exposure, avoid smoking and passive exposure to smoking, and avoid irritants. Then they give some symptomatic that you should screen people for lung cancer and various cancers. There's a 6-minute walk test that they actually describe very in depth and say that this should be done fairly consistently every year to see how it's advancing and see how the person's doing. Watch for acute flare-ups, and there are some, again, it's very small in the section that says that you might have some pharmacological intervention. Then there's the prevention section. You know, you would probably be responsible based on these guidelines for immunizations for things like pneumonia and flu.
Now, COVID.
Aggressive rest, not COVID.
No, and I would say, and now COVID, because I can't
yeah,
imagine that it would be good for somebody. I mean, once we have a vaccine.
Yeah, I think that would be true too. And same thing with aggressive respiratory infection treatment. The guidelines say that if somebody does have this interstitial lung disease, you need to be very aggressive in treating the infections that someone gets. And the infection would obviously not really be related to it, but it would be aggravated because of it. Supportive oxygen treatment during sleep and cardiac complications are listed in the treatment section of the medical treatment guidelines. And B7A, which is just a sentence, and the sentence is written in the guidelines as it is here. In advanced or rapidly progressing cases, a lung transplant should be performed.
Wow.
Which is the smallest guideline I've ever seen for something so major. But I'm assuming that that there's no doctors just performing lung transplants for the heck of it.
I also think it's interesting that the treatment encompasses the preventative care to prevent cardiac complications, because it seems to me that if the person comes to you with a cardiac issue, that in order to care properly for their interstitial lung disease, if you need to prevent cardiac complications, then you need to prevent their you need to pay for their treatment, apparently. I mean, that's, I think, taken at its broadest interpretation, that might lead to liability for what was already a pre-existing condition.
Yes. So I think that that's absolutely true, that these guidelines do really broaden what you could be caused to pay for. So really the trick in these guidelines, or not the trick, but the goal in these guidelines is to really differentiate between the initial diagnosis and fight it off the beginning of the claim, which is what the guidelines are mostly dedicated to. Okay. And the last, go ahead, Melissa.
Yep. Oh no, I said good advice. And I advanced your slide.
And this slide is wrong because this was before I did all my rules. So it's the two people with the most correct answers who email in the quickest amount of time. Ties will be based on who answered first, and all answers must be received by 4 p.m. So I already got one, and I didn't check it yet to see if it was right. But
well, that person clearly wasn't paying attention, so they're going to the bottom.
No.
All right. So that was great. So do you want to open it up for questions? Because I can unmute everybody.
Sure, you can open it up for questions, but I can't see. They might have to come through. Oh, no, I can hear the meeting, so go ahead.
Right. Okay, so everybody, I'm going to unmute you. So if you were actually watching Jerry Springer in the background, just be aware that we're going to be able to hear that in a second. Okay, everybody should be unmuted who wants to be unmuted. If you've put your own mute on, then I was unable to unmute you. So for example, Brian, if you want to say something, you'll have to unmute yourself. Does anybody have any questions? Other than what's the answer to slide number 7?
I mean, I'm inherently curious as to what the fee schedule is for lung transplant, but.
Yeah, if somebody in the audience can answer that for us, that would be awesome. All right, well, it seems like everybody is satisfied with the knowledge that you've imparted to them, Shannon, on interstitial lung disease. I'm telling you, I learned a ton of stuff about interstitial lung disease that I did not know. And given both of our mutual experiences at Special Funds dealing with dust diseases all the time, that's fantastic. I feel that you really went beyond the presentation to explain a lot of things to us, and in addition, gave us a great overview of what the board is going to be expecting. So thank you very much. As Shannon said, if you have any questions, feel free to email Shannon at smackey, Mackey, at madwcdefense.com, or I'm always happy to talk to people about comp because I really have no life. And I just, again, I'd like to do a shout out to Leah Zakari for our awesome song. So thanks for tuning in. Next month, we
Thank
will
you.
have another set of the new guidelines. We're going to bring another set of the new guidelines to you. I'm not sure what it is off the top of my head, except that I'm pretty sure it's not top of my head as the guidelines because the board didn't issue any guidelines on the head. So have a great weekend, and we will see you next month. Thanks for tuning in, and thanks for your patience today with our technical difficulties, everybody. Take care.